I'm Kim Suderman, and I'm currently a consultant for the County Behavioral Health Directors Association. I used to be a behavioral health director, and today I want to talk about trauma-informed care. When a person is trauma-informed, it means that they understand that a person, today we're talking about children and youth, has experienced some sort of trauma. And because of that, their reactions or behaviors may be outside of what one would expect to see in a situation. And our kids today, because of their experiences, are not reacting the way everybody expects. A trauma-informed care person would know that and not be frustrated with that, but want to see how can we help that child go through and deal with the trauma they've experienced. So kids may experience physical trauma, meaning they were injured in some way. They may be a witness of some horrible experience. They may have just experienced ongoing, nonstop verbal abuse. If you think about water dripping, it's irritating, and after a while you start to get used to it, and pretty soon you don't hear that water dripping anymore, and that starts to become normal. Children that have experienced just non-stop ongoing trauma may start to think that that's the norm, and their reaction to protect from that, they've settled on how they're going to take care of themselves, and it's not healthy. And so then they're kept from being able to do and experience the things that they should be as they grow older and become an adult. If we don't know what happened to a child, if as a clinician or therapist, I don't understand what's going on, if as a social worker or probation officer, and I don't understand the basis for what's going on for the child, I'm probably going to be unsuccessful. I'm not going to be able to help the child in the way I should as a therapist. I'm probably not going to find a placement or a natural consequence that the child should have that will successfully help that child grow and learn. So I'm likely to be unsuccessful. The child will likely experience another trauma. Being placed again, being moved, having to change therapists, having to go through multiple system settings, that's traumatic. Some of it can't be helped. Staff come and go. But each time there's a change for a person that's already been through a trauma, they're getting re-traumatized. If we can avoid that or keep it at a minimum, and meanwhile, help them address and transition safely, emotionally safely, then we can at least help them continue on that path of health and growth. So one of the things that I think is important, if I'm a clinician, I should be sharing, not details because I know I have to honor confidentiality, but I should be sharing with the rest of the child and family team, the caregivers, what are the triggers for the child, what to watch out for, and how to help them. If I'm the placing worker, social worker, or probation officer, I should be asking the clinician and other people who know, what are the triggers? What should I watch out for? How can I be helpful? What activities would be helpful and what activities to avoid? If I'm a foster parent or even a relative caregiver, or even I'm getting ready as the biological parent to get my child back, what should I be watching for? I should be asking some of those same questions. What happened, or what can I notice that will help the child that I'm now taking care of do better? And what should I avoid? We don't have to have tacos once a week if that's something that's a trigger. We can have something else. And so can be simple things. What's the child's favorite colors? What are the things they like? What are the things what's your favorite sports team? We need to be interested in the children and the things that they're interested in. And just recognizing that, the kids will know you care. And that's the beginning.